Hello, my name is Ian McCall, and this is another in the Consultations in Dermatology series from the Australian Institute of Dermatology. Today we're going to look at pemphigus in its various forms, and note that we've entitled it blisters and crusts, because that's essentially how pemphigus will present. It'll present as a blister, and if the roof comes off, as an erosion, or it'll present as a crust without much in the way of history of blisters. And the way in which it presents depends on the level of cleavage of the epidermis, because pemphigus is an autoimmune disease in which the body produces antibodies and cells that attack the desmosomes. These are proteins that link the keratinocytes together in the epidermis. These are the proteins that hold the epidermis together, and they're called desmoglions. And from memory, I think there's about 6. But the main ones that are involved in the various forms of pemphigus are desmoglin 1 and desmoglin 3. Now, quick bit of pathophysiology. Desmoglin 3 is found in the mid to lower part of the epidermis, and desmoglin 1 is found in the upper part of the epidermis. Desmoglin 3 is also found on mucosal surfaces, whereas desmoglin 1 isn't. And the knowledge of that helps to explain the pathophysiology and the clinical presentations of the various forms of pemphigus, particularly Pemphigus Vulgaris, which is very superficial and will present as crusts, and Pemphigus Vulgaris, which is a bit deeper and will present with blisters, erosions, sometimes some crusts as well. There can be a degree of overlap of the two conditions, and some people can go from one into the other in terms of the clinical manifestations. But the important thing is that oral lesions are only seen in Pemphigus Vulgaris because the antibodies are directed at desmoglin 3, and that doesn't happen in Pemphigus Vulgaris, where it's only directed at desmoglin 1, because remember, it's the oral mucosa that has desmoglin 3, as well as the midpoint of the desmosomes at the midpoint of the epidermis. Okay, we're laboring this a bit. Let's show you a few bits and pieces of this condition. Now remember, this is a severe autoimmune disease. This is a disease that can kill people. It tends to affect the elderly. It's certainly a lot less uncommon than bullous pemphigoid, which is the other autoimmune disease, blistering disease, that affects the elderly. And Pemphigus Vulgaris must be 10 times less common. I mean, I've just got that off the top of my head, but just from clinical experience, that's what it seems like. Now, these are some of the images, but I think we'll look at these images as usual in the form of a PowerPoint presentation. So bear with me while we get that up. Okay, blisters and crusts, pemphigus. This was just the clinical. To go over it again, the various types clinically depend on which desmoglin protein is attacked. The desmoglin proteins are the desmosomes holding the epidermal cells together. Remember this last bit. It's a severe, persistent immunobullous disease requiring oral steroids or other immunosuppressant drugs to keep it controlled. The actual cure rate of this condition is possibly 10% or less. It tends to be a condition that you control. So here's a presentation of erosions of Pemphigus Vulgaris. The splits at the mid-epidermis. Most of the top layer of those blisters has fallen off, and you're left with some erosions here. There may well be a bit of secondary staphylococcal infection. You can see the degree of oozing that's occurring in this particular patient. The thing about Pemphigus Vulgaris is that it often presents with oral lesions before there are any skin ones. And remember, that's the desmoglin 3 protein that's being attacked, that's in mucosal areas. And it can present as a gingivitis, where only the gingiva is affected, or as in here, where it's hitting the part of the soft and hard palates. And you can see the erosions which are coming. This is the top surface of the tongue here. You can see these painful erosions. But as I say, it can present as localized ulcers, and it can present as a severe erosive gingivitis. And 90% of Pemphigus vulgaris patients will present with oral lesions before they'll present with the skin ones. Now, your differential for the oral lesions is conditions such as erosive lichen planus. You'd also have to think of the Sutton's type of ulcer that you see in some forms of Crohn's disease, where they can have these aphthous ulcers in the mouth. But essentially it's lichen planus that's your main differential. Now, how are you going to investigate a case of oral or skin Pemphigus vulgaris? Well, it's biopsies, and we'll show you these in a minute. For H&E and direct immunofluorescence, we said this is an immune bullous disease, and the immunoglobulin is directed between the cells. We'll show you that picture shortly. You also look for Pemphigus antibody titers, bad spelling, because you can measure these fairly easily in the blood, and the rise and fall of these titers normally gives you some useful information as to how well you're controlling this condition. The condition can respond rapidly to high-dose oral steroids without the antibody titer changing terribly much. So the steroids are acting in a different way other than just reducing antibody levels. You're going to do your routine bloods because the drugs you're going to use are going to are quite serious drugs, and you need to know that the patient's got reasonable kidney and liver function. And you do the quantiferin gold test because that picks up if the patient's had TB before or atypical mycobacterial infections. And the problem is that the drugs you're going to use in treating pemphigus will suppress the body's immune system, and so if they've got one of these diseases that they're sort of controlling just and holding, then it can break out when they're on those drugs. So these are the main investigations that you're going to do. There's your pathology of Pemphigus vulgaris, the desmoglein 3, the lower part of the epidermis here. Often the basal cells, the basal layer cells, stand out like this, separate from each other, but still adherent because they're only hemidesmosomes here. And this is called the tombstone effect. They're like a line of tombstones, the residual basal layer that's left here. The split, the separation, the rounding up of cells, this is called acantholysis. And you can see you've got a relatively thin-walled blister on the surface, and this will break and often cause burst and cause erosions. So this is Pemphigus vulgaris. Often not an awful lot of perivascular inflammation. Occasionally you'll see eosinophils here, and sometimes in very early cases, before the acantholysis has occurred, you'll just see some separation of the epidermal cells here. And it may be reported as an eosinophilic spongiosis because there's eosinophils, and the spongiosis is just a separation of the keratinocytes. So early on, if you get that sort of histology, don't let it put you off. It could still be early Pemphigus vulgaris. There's just another example of a combination of some blisters, which are still to be seen here, where the skin's come away here, giving these erosions. And so, as we say, superficial blisters and erosions of Pemphigus vulgaris. Here's another case on the back, but you can see there's a variety of other things here. You've got crusts here, where the overlying epidermis is shriveled up and there's been some exudate and it's formed these crusts. There has obviously been some blisters here and they've healed. This is an example of the blister here that's healing. So it can present mainly as erosions without much in the way of blisters. If you look very carefully, though, you may well see a flaccid, slightly pus-filled blister like this. And that's not going to last long. It's going to burst and form an erosion or a crust very quickly. Here's the other type of Pemphigus, Pemphigus foliaceus. Now in Pemphigus foliaceus, it's desmoglein 1 that's involved. Therefore, there's no oral lesions, and it's very high up in the stratum granulosum, just underneath the stratum corneum. So they tend to present with lots of crusts. Not a lot of erosions, but lots of crusts. And so they may present like this, and it can be a difficult diagnosis to make. You may look at this and think, what have I got here? Is it some form of staph infection with crust formation? Here's another example of it, of Pemphigus foliaceus, fairly early on. That's the person's back as well. Curious figured appearance. Look at the involvement perianally here as well. Can be a tough diagnosis to make. Sometimes you think it's bullous impetigo. This is where the split is, through the stratum granulosum. Very high up here. This is where the hyaline granules are in the stratum granulosum here. And so it's a very high up split. This, you can suggest there's a little bit of spongiosis here as well. These are the spinous, the desmoglein proteins in the spinous layer. These little things you can see going across the spaces here. But it's the ones up here, desmoglein 1, that are affected. And this is the immunofluorescence of this condition. This actually is the lower part of the epidermis here, not the upper. So this can be early Pemphigus vulgaris. And see how the antibody is deposited round about the cells, affecting these desmoglein proteins. And so it outlines it net-like, like this. Here's another example, where again, all the immunoglobulins, IgG, and I think C3, are deposited in the spaces round about the cells where these desmoglein proteins are. Now, there's a few other types of pemphigus that you should be aware of as well. And one of them that we're seeing perhaps more of is paraneoplastic pemphigus. This is where a pemphigus-like syndrome is associated with an underlying malignancy. And it's usually seen with B-cell lymphomas and non-Hodgkin's lymphomas, thymomas, it's tumors of the thymus gland, and a rare lymphoproliferative disorder called Castleman's disease. You need to look that one up. The thing about it histologically is not only do you have the antibodies in the directed to the desmoglein 3 proteins, you also have antibodies directed to the basement membrane. And this can give rise to some lichenoid features. Let's have a little look here. Look at the degree of erosions in this patient with paraneoplastic pemphigus. There's some aspects of healing trying to go on here, but this is where the surface layers have all peeled off and you've got these erosions. Similar picture here. Varying degrees of damage to the skin. Much more damage down here. Much more florid erosions have occurred. This was the guy's back. You can see the surface splits here. This is more, you could argue, Pemphigus foliaceus-like, where the split's much higher up and you're getting this crusting formation. So that's what I was saying, there's a mixture of patterns that you're going to see. Now, paraneoplastic pemphigus, to investigate it, it's the same as the others, but also you've got to look and examine the patient for those underlying forms of malignancy. Rarely other malignancies such as stomach or lung or certainly chronic lymphatic leukemia can present with paraneoplastic pemphigus. So you've got to go looking for these other disorders. Pemphigus erythematosus is probably just another variant of Pemphigus foliaceus, except that the distribution is unusual. It's mainly on the face and the sort of malar distribution here, with the more crusting picture that you see in the superficial type of Pemphigus foliaceus occurring on the anterior chest wall. They also can have antibodies directed at the basement membrane, a little bit like you see obviously in lupus erythematosus. So they have a double picture of antibodies, antibody deposition. But it's mainly a clinical sort of diagnosis based on the distribution of the lesions, Pemphigus erythematosus. Then you can get Pemphigus vegetans. This is where pemphigus can remain localized to an area for some time, and you get this thick buildup of crust and the like. Again, it's more commonly a variant of Pemphigus foliaceus with thick buildup of crust, often seen in the scalp like this. So consider that. I mean, you might look at that and think it's some form of malignancy, maybe a carrion, or some other type of infective process. But in point of fact, always, maybe you're thinking of crusts and erosions, pemphigus should come to your mind as well. And this is Pemphigus vegetans. You can get the same picture in flexures as well with some patients. So the other things I haven't mentioned there, and I should have mentioned a little bit about drug-induced pemphigus. There are a few drugs that can do this. Penicillamine used to be, this was one that I think was a chelating agent of some sort. I think it was used in rheumatoid before. I don't think you can even get it nowadays. But it could cause a pemphigus picture. And so also can captopril, which is used in blood pressure management. So you've got to consider those two drugs as being, we'll certainly look for them, see if there's any evidence of the patients that on these drugs. How are you going to treat these patients? I think the first thing to remember is that only a very small proportion of these patients ever actually are cured of this disease. Many patients, in fact, die as a result of the treatment that they're given, in the sense that these treatments are often immunosuppressive and they may get other infective disorders. They're old people anyway. They often have a lot of underlying morbidities. And so some patients die because of the treatment. Now, that's not to say that you shouldn't treat them, because it's a miserable thing to have pemphigus with the smell, the erosions, the crusts, the local pain. It's not a good condition to have. So we've already mentioned that if it's paraneoplastic pemphigus, you've got to look for the underlying malignancy. If you can deal with that, then the condition may improve and improve markedly. So it's worthwhile treating the lymphoma, treating the leukemias if you can, and the paraneoplastic pemphigus may well improve. Pemphigus foliaceus doesn't have the same mortality as Pemphigus vulgaris. There's not the same erosions and not the same weeping, and patients with Pemphigus foliaceus can go on for years with relatively straightforward, simple treatments. Vulgaris, it's more difficult. You need higher dose of steroids, higher dose of other immune suppressant drugs. Occasionally, if you just got a bit of localized pemphigus, you can get away with strong topical steroids, you know, your Diprazone OV, your clobetasol, just applied, some intralesional steroid by injection, Kenalog or the like. But it's not for long, because you can imagine the antibodies then tend to attack other areas, and they end up, most of them, needing oral steroids. You need somewhere between 60 and 80 milligrams daily for vulgaris, somewhere between 40 and 60 for foliaceus. And then you often have to add in a steroid-sparing agent. Azathioprine can be used. I haven't got that up there. And mycophenolate mofetil is the other one that's used. This is an immune suppressant used in transplant patients. You'd need to check up on doses and the like, but it's just another one that can be used, and you can gradually reduce your dose of oral steroids. The steroids, we don't know how they work. As I've said earlier, the patient can improve quickly when they're on those drugs before their antibody titer drops. So it suggests that perhaps the steroid leads to some improvement in the making of more desmoglein protein, and the epidermis is able to hold itself together better. It takes a while before it's going to act in the immune system and reduce the actual production of antibodies. Cyclophosphamide is a very efficient and effective drug in Pemphigus vulgaris, and I must admit I've used that drug in many patients and gradually reduced their steroids, and often been able to run them in the longer term just on cyclophosphamide itself. Now you've got to watch it. It can affect the bladder. It also can affect the blood. So it's a drug where you have to monitor it, but I've found it quite a useful drug in the few patients with pemphigus that I've treated. Plasmapheresis is a method by which you siphon off or filter off some of these immunoglobulin molecules, and it can be useful in the short term to give someone relief, but you need a specialist center to be able to carry that process out. Some specific forms of IV immunoglobulin therapy can be used, which seem to have a beneficial effect in patients with pemphigus. A drug called dapsone can be used. Dapsone is usually used for dermatitis herpetiformis or in leprosy, but it's anti-inflammatory, and there is a type of pemphigus called Iga Pemphigus, which looks like you get subcorneal pustules, and it may be the same as a condition called Snedden-Wilkinson disease. You may need to look that up. But in that particular type of pemphigus, it's not IgG that's attacking the desmosomes, it's IgA. And dapsone seems to be very effective in IgA disorders. Oral disease, so if you've just got a gingivitis, then a dental tray with some form of steroid gel or ointment in there, worn for 3 or 4 hours a day, can be quite useful to reduce the inflammation in the mouth. But a lot of these patients also get candida, so they need some oral fluconazole to deal with the candida. And we said earlier on, you do the quantiferin gold test to see if there's any history of TB, and if there is, then you should, when you're giving these steroids and other immunosuppressant drugs like this, you should use some isoniazid, 300 milligrams daily as well, to give them protection against resurgence of old TB that they've had. It's a tough condition, this, to manage. There's a lot of nursing care involved in dressing the ulcers and the like that these patients get, and the erosions. You need pain relief for them as well. You certainly need often a mixture of nystatin and lignocaine gel for oral pemphigus to try and relieve the pain that's there. And you've got to be always on the lookout for other infective disorders. And the steroids, of course, can induce blood pressure, can induce diabetes. So you've got to be on the lookout for that as well. And other rarer side effects like necrosis of the neck, of the head of the femur, can occur with high doses for some time. So the whole idea is to try and get the steroids down and get a minimum dose along with these immunosuppressive drugs that they can use in the longer term to give them relief. These are rare diseases. As a dermatologist in private practice, you don't really see them terribly often. So it's often important to perhaps refer them to a tertiary center where they perhaps have a clinic that specializes in immunobullous diseases and have these patients managed there. But of course, not all of us have the luxury of being near a center like that to refer a patient, and so one still has to get an awareness of the general principles in managing these patients. And let me end up a little bit on prognosis. I've said that only less than 10% will actually go into a permanent remission after some years of treatment. Most patients you can get away with less and less doses of drugs, but they'll still tend to flare at times. Pemphigus varies from area to area of the world. Some areas, like Brazil, there's a condition that seems to be associated with an insect bite called Pemphigus vulgaris, and it's like Pemphigus foliaceus, and it's seen in people who live down by riverbanks where a particular fly seems to spread this disease. How it does it, and we really don't know, because we still understand it not as an infectious disease but as an immunobullous disease. But the condition looks awfully like Pemphigus foliaceus. Some parts of the world, say in Pakistan, Afghanistan, there's a high incidence of Pemphigus vulgaris in those. But there's a really very low incidence in Australia of this disorder. It's probably, 1 in 500,000 of the population. Whereas in some of these other parts of the world, it's 1 in 100,000 of the population, or even more common figures than that. So, though a rare disease, it's an important disease to know something about. It's a condition that I think you should recognize mainly because of the oral presentations if it's Pemphigus vulgaris, and because of the crusts and perhaps slight erosions if it's Pemphigus foliaceus, again in an elderly patient. it's that just being aware of the disorder and the way in which it presents. I consistently fail to make this diagnosis, this one here, Pemphigus Vulgaris. I just don't recognize it at first. I've just got to keep telling myself, no, crusts in an elderly patient, it's either they've got some form of staph infection, one of the bullous staphs, or they've got Pemphigus Vulgaris. I've got to remember to make, and the thing is, you can swab them and get a bit of staph there and think, oh yeah, it's just a bullous staph infection with crusting. And it isn't. It's early Pemphigus Vulgaris, and they do need a biopsy and immunofluorescence. So if we get that little message across from today's talk, then perhaps we'll save some elderly person from having this condition undiagnosed for a reasonable bit of time. Interesting disease. Read up about it. It's well worth it. Thank you very much.